Good morning. 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 Hello. 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 Well, sometimes it works, sometimes it doesn't. Yo. Hello. 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 Yeah, bloody freezing. Come on, you. Come on. Come on. Come on. Come on. Okay, system, what's wrong with you today? Hello, hello, hello. Bloody thing. two of yours. All right, it's time to get started. So I hope you brought the case studies from last time. We're going to work on those today. I hope you might have had a chance to take a look at a few of those. These, by the way, are real studies from the literature. These aren't made up from my pointy little head. These actually are things that appeared in various publications. Granted, they're abbreviated, but this is essentially what happens when you get two drugs together in the same patient whose pharmacokinetics can interact. So you can get drugs either expanding in their half-life, you get greater concentrations, you get toxicities, or the drugs get degraded because the cytochrome P450 is induced and you get treatment failure. You have cases of those in these. There is one case, case number 9 that has nothing to do with cytochrome P450. That has to do with lithium, and lithium is excreted by the kidney, pretty much exclusively by the kidney. And if you decrease kidney function, and there are several drugs that will decrease kidney function, lithium levels can go pretty high. And one of the side effects of lithium, I don't know if you've known anyone who's on lithium, you get what's called an essential tremor. So a test you do for patients on lithium is you have them draw a spiral like that. The patient on lithium, their spiral will look like this. The differences between having an essential tremor and not having an essential tremor come out in this test pretty easily. You can see them pretty unmistakably. So if your lithium gets really high, your tremor gets a lot higher, and you also start getting spacey. You have to go to the bathroom all the time, and yeah. No, people with Parkinson's can have tremors as well. Also, some types of neurological diseases. Now, don't confuse tremor with, there's this condition called akathisia, which you get from certain antipsychotics. Akathisia is, there are videos, just type akathisia into YouTube, you'll see videos of people with akathisia. You can't miss it. It's someone who just, they can't sit still. They're just interminably restless. That's several antipsychotics cause that, in particular, aripiprazole. Abilify causes akathisia, particularly at higher doses, tends to be dose dependent. But that's different than tremor. Tremor is just a shake, usually in the hands. If it gets worse, then it can be in the head too. You can get this sort of thing, or sometimes that sort of thing too. But it's usually in the hands, usually, unless their lithium levels get really high. Then they'll start to That's different than akathisia. That's, yeah, different. All right, now, diet can also influence drugs. Probably the best example would be foods that are rich in vitamin K. And warfarin, because warfarin works in your body by interfering with the vitamin K induced modification of clotting factors. If you eat foods rich in, that's a K, by the way, foods rich in vitamin K, they can decrease the effectiveness of warfarin. So those of you in nutrition, how many of you are in nutrition? Okay, you get to show me how smart you are now. Give me some foods that are rich in vitamin K. Haven't covered that yet. Jicama, kale, watercress, things like that, things that nobody eats. Those foods are rich in vitamin K. So if you eat kale or jicama or Brussels sprouts, my daughters got me into roasted Brussels sprouts over the pandemic. They're actually pretty good. But Brussels sprouts are kind of the vegetables you make fun of, because everybody hates Brussels sprouts. It's the food we all like to gang up on. Yeah, Brussels sprouts. That doesn't work as well with a mask on. But hey, if they're roasted, they're actually pretty good. So anyway, if you eat and if you call on warfarin, there's a sheet you give the patient, and it has a list of foods rich in vitamin K, and that will tell you these are the foods you need to moderate. Actually, if you eat them, you need to eat them all the time, because then your warfarin levels should be stable if your diet is stable. Well, whose diet is perfectly stable? That's the problem. Another example, and this is kind of interesting, there's an antipsychotic called ziprasidone. The trade name, Geodon. Anyway, in ziprasidone, sorry, there, I'll learn how to spell. Ziprasidone in studies, it wasn't very effective. Then it turns out the drug is very lipid soluble. In order for it to be absorbed, you have to eat it with a fat-rich meal. Once people figure that out, all of a sudden, the efficacy of this drug really skyrocketed. It's a really good drug for schizophrenia or certain types of personality disorders or various other conditions and what have you. So that's another example where absorption of the drug is greatly affected by what you eat. Another one, your tetracycline. So doxycycline, minocycline, and then some others. There's a new one now for acne, serenocycline. There's a new one, just came out beginning of last year, called amatocycline, which is for really severe skin and skin structure infections. These drugs are very, very well absorbed. Their bioavailability is either 100% or close to it. But if you take them with calcium or iron, these form complexes with these drugs. They go right through your system. You don't absorb them. Now their bioavailability is more like 30%, 40% instead of 100%. So you're never sweet. Your doctor or pharmacist may tell you to take those drugs on an empty stomach. My doctor told me a very amusing story. about a patient he had who had a bad sinus infection. So he gave him doxycycline. And he came back a week later and said, this stuff doesn't work. And he said, okay, just tell me how you take it. He said, well, I finish dinner and then I take the pill and have a nice tall glass of milk. Now, what's wrong with having doxycycline with a nice tall glass of milk? Milk is dairy. Dairy's full of calcium. Calcium grabs the doxycycline, goes right through your system. You don't absorb it, so the drug doesn't work. And he said, okay, I'm going to write you a new script. This is the way you're going to take it now. You're going to take it on an empty stomach. And lo and behold, his doxycycline started to work. So diet can affect the efficacy of some drugs, either because of absorption or because of pharmacodynamic considerations. Secondly, disease states can also affect drug metabolism. So if the drug is metabolized by liver enzymes and you have either hepatitis or you have liver cancer or something like that, that can affect drug metabolism. If the liver is inflamed, very often drugs won't get metabolized well at all. This is actually a benefit if you're treating hepatitis C. So several of the drugs used to treat hepatitis C, there's a drug combination called Harvoni. Both Harvoni drugs, sofosbuvir and Despactovir, are metabolized by cytochrome P450s, but because the liver is infected, they don't get degraded very fast, so they're much more effective against the virus. And as the liver gets better, the drugs get degraded faster, and that becomes a measure of how well the drugs are working. Liver cancer, some P450s actually go up, others actually go down, depends on the liver cancer. So you have to usually test your patient for which ones go up, which ones go down, which drugs will be chewed up really quickly, which ones won't be chewed up at all. And then cardiac disease, because blood flow through the liver and blood flow through the kidneys will determine metabolism and elimination. Your half-lives can be greatly affected in a person with some sort of cardiac disease. So you'll have to adjust doses accordingly. One thing that's not on here, that probably should be, is renal disease. If you have a patient with renal disease, the half-life is usually much higher. So typically, it's recommended you start at the lowest possible dose and then work your way up as needed. And now a bit of humor from the pharmacological world. Hey, diddle diddle, the cat and the fiddle, the cow jumped over the moon. Well, here's why the cow jumped over the moon. Those of you who drink coffee can probably relate to this. Okay, let's talk a bit about acetaminophen, because this illustrates how you can have two different types of processing of a drug, phase 2, phase 1. These can work together for your benefit or to your detriment sometimes. So acetaminophen primarily is metabolized by phase 2 reactions. There's a small little bit that gets metabolized by cytochrome P452E1 to this metabolite N-acetyl P-benzoquinoamide, which is mercifully abbreviated NAPQI. NAPQI is toxic to cells. Normally, you make so little of it, when you take acetaminophen, it's of no consequence. Your body deals with it, and it doesn't kill any liver cells or anything like that. Now, you're only supposed to take up to 4 grams of acetaminophen a day. If you go over that, cofactors for these reactions are exhausted. Now you metabolize the drug this way. Now you make more of this metabolite than you can handle, and you start getting liver damage. And to illustrate how this might be a problem, let's say you go out and celebrate by enjoying the fruits of the vine. And you enjoy the fruits of the vine a bit too much. And so you wake up the next day, you are what technically is known as hungover. So for your headache, you take acetaminophen. Guess what drinking did? It exhausted these cofactors. Now you're going to drink acetaminophen, you're inviting your liver to have liver damage. In fact, a good proportion of people who need liver transplants kill their liver exactly this way. So what's the upshot of this? If you're hungover, don't take acetaminophen. You'll kill your liver. It's alcohol is processed by alcohol dehydrogenase. That makes acetaldehyde, and then acetaldehyde circulates through the body, but it's detoxified by glutathione. And glutathione is the cofactor used in this phase 2 reaction. So after you had a binge, to use a term, to coin a phrase, turn a phrase, whatever, your glutathione is really low. So your body says, don't have glutathione, so we'll go this route. And you kill your liver. Ibuprofen. Or just don't get plastered the night before. Okay, little story. So you guys know I grew up on a farm, and the people I used to work with out in the fields were Filipino and largely Latin Americans. And Latin Americans, they, on the average, genetically, they tend to metabolize alcohol very quickly. So they get inebriated really quickly. And they used to always tell me, yeah, I went to the bar and I had a bit too many and I got in a fight. I said, why'd you get in a fight? He said, when I drink, I get aggressive. I fight. Really? Yeah. My friends do too. It's in our blood, you know? Like, really? Okay. He said, well, what happens when you drink too much? I said, well, one, I don't like alcohol. So I don't know what I do when I drink too much, but I know when my relatives do, when they get drunk, they sing. They don't fight, they sing. He said, really? I said, yeah. And they don't sing very nicely either. So it's in our blood. So, and we had a good laugh at that. And he used to call me Caruso, the opera singer, whom none of you have heard of. He used to call me Caruso then after that. Hey, Caruso, good morning. And that was anyways, just cultural joke at the expense of each other when I was in the fields picking grapes with my buddies. Anyway, so this metabolite, the NAPQI, gets metabolized rapidly with glutathione to this metabolite that's pretty easily excreted. That's why if you have plenty of glutathione, even making a little bit of NAPQI is of no consequence. When, however, glutathione is depleted, now you're going to have a problem, and alcohol consumption will actually induce CYP2E1, and that increases NAPQI production, and it depletes glutathione. So you can see by this combination of alcohol of acetaminophen after alcohol is a rather deadly combination for your liver, and it has to do with the way it's processed. And acetaminophen overdose is a common cause of liver failure. In fact, a third of all liver failure cases are due to acetaminophen overdose or acetaminophen use after alcohol use. Yeah, some people, there are alternative pathways your body develops to process alcohol. That's why people who drink a lot tend to develop a tolerance for it. And you're still going to experience liver toxicity if you take acetaminophen, if you've had too much to drink the night before. It's the way it goes. Let me just address one thing. You see this on the web a lot. If you drink, the dictum on the web is if you drink, how's it go? If you drink hard stuff first and then chase it with cheaper alcohol like beer second, that's supposed to protect you from getting drunk. So if you drink your beer first and then drink your higher quality alcohol later, that's supposed to keep you from getting drunk. That's baloney. Here's why. The one thing that will determine whether or not you get drunk is your body weight and what percentage of alcohol and how fast you drink it. How fast you drink it. That determines whether you're going to feel the effects of it. Sorry. It's not what you drink, it's how quickly you drink it and how big a person you are. So, for example, let's just take Chapman back there since he's a big strapping chap. Chapman, I'm sure, can drink Lydia under the table, okay? There's just no two ways about it. Lydia is wonderfully small and petite, and Chapman is a big strapping chap. That's just the way it works. I'm sorry, Lydia, I'm sorry. So if Lydia, however, sips her drink and doesn't gulp it down, chances are she can make that last throughout the night, and she probably won't feel fine the next day, is where Chapman will have a splitting headache. It has to do with how fast you drink it. How fast you drink it, that will determine how much you drink. And even something that's not a lot of alcohol, if you drink it too quickly, can actually affect you, because it's that the amount of alcohol your body's exposed to at one time has as much to do with how much effect it has on you. So I don't know if you've seen that dictum on the web, beer first, wine later, wine first, beer later. No, depends how fast you drink it and how much you drink given your body weight. That's the determining factor. Acetaldehyde crosses the blood-brain barrier. It dehydrates the brain to some extent, so the brain is contracted a little bit. Also, you get vasodilation of the brain. And if you're prone to migraines, often a binge will usually stoke a migraine. Typically, that's actually quite common. In fact, alcohol may stoke a migraine in some people. And then usually B12 stores have been used up as well. You have a B12 deficiency. That's why some people say if they're hungover, they eat a red steak, because that increases your B12 intake. Takes a while to absorb the B12. I'm not so sure that's a good idea, but that's the other reason for that, the headache as well. And then the lassitude, that's the acetaldehyde. That's the brain trouble. Yeah, I had no intention of talking about alcohol this much, but the interest is there. So anyway. Now, alcohol, believe it or not, can be partially protective if you're taking it while you're taking the acetaminophen, because alcohol is partially metabolized by 2E1. Therefore, it competes with acetaminophen for 2E1. Because it competes with acetaminophen for 2E1, it'll prevent the conversion of acetaminophen into NAPQI. So if you take it with acetaminophen or shortly after, excuse me, acetaminophen, then it might be partially protective because of that competition for cytochrome P450 2E1. And this essentially just illustrates the chemistry involved with the acetaminophen. That's acetaminophen. I think in organic chemistry lab, you make this stuff. It's not that hard to make. And you can make a glucuronide or sulfate adjunct to it, or a glutathione adjunct to it. And you can partially metabolize it with 2E1, and then glutathione gets rid of that. And but here's the NAPQI, and that can lead to, that derivatizes protein and can lead to cell death. Cells can take a little bit of this. If they get a lot of this, then you lead to cell death. Okay, let's take out our handout from last time.
Brewing company is that like there was like bad water in the country and he wanted to like make something that like people experience without getting sick and stuff. So like basically in that analogy, you're replacing water with alcohol, right? Like is that actually like is that like a good idea though?
Well, you must remember that the early in this country, there were no pure food and drug laws. Water quality was very poor.
Right.
So alcohol has a bactericidal effect. And so low concentration alcohol was actually better for you health-wise, didn't have the bacteria in it that other water sources had. That's not the case anymore, but that was the case back then. Okay, let's have some people kind of serve as discussion facilitators. So I'm going to pick on Kelsey. Kelsey, let's have you do problem 1. So if you want to work on problem 1, come see Kelsey. She's all about problem 1. And then let's pick on Hope. Hope, you want to do problem 2? Dave, you want to do problem 2? Come see Hope. She's all about problem 2. And then, oh, Greg, which one should I give you? Oh, painkillers. You're going to be a dentist, so you'll be all about pain. Let's do problem 3. We're going to do problem 3. Come see Greg, future dentist. And number 4, I'm going to pick on Jessica. So Jess, you lead the group for number 4. So if you want to do 4, go see Jess. Remington, how do you feel about number 5? 5? 5 works for me. Okay, let's do that. And let's see. Lydia, you want to do number 6? Sure. Okay, so if you want to do number 6, go see Lydia. John, how do you feel about number 7? You're good with number 7? Okay. I'm going to work on 7. Go see John. And then, oh, Katie's back. Katie, how you doing? How's your friend? She better? Oh, good. I'm glad to hear that. Okay, good. Zach, welcome back from quarantine. You have another worksheet? I'll tell you what, Emily, I think, has it. Yes? Why don't you and Emily work on 8? And if you want to work on 8, go see those 2. And then Zachary, why don't you do number 9? Number 9, okay? So if you are a designated group leader, go ahead, raise your hand. And then also use your fingers to indicate which problem you've been assigned. Go ahead, find a group leader and work on your problem. Yeah, look stuff up. Use your phones. Look stuff up. That information should be available. Okay, guys, fluconazole, but phenytoin. Phenytoin is notorious for the drugs it interacts with. So the big one here is going to be phenytoin.
We're doing 3.
We're doing 3. Okay. Codeine. What do you know about codeine? I told you something about codeine. Sorry?
Is it uninduced?
No, but it is a opiate, but it has to be converted into something. It's a prodrug. It's a prodrug. It's a prodrug. So keep that in mind. There you go, Josh. Look it up. Look it up. That's also a 3A4 substrate. Keep that in mind too. Phenytoin is notorious for the drugs that it induces or inhibits with, yeah.
It has
You know, that's not just a 3A4 substrate. It's also a substrate for another enzyme too. One that phenytoin tends to mess with pretty badly.
Drug transporter P glycoprotein? Would that be it?
Sorry?
P glycoprotein?
P glycoprotein is, well, it's also a substrate for P glycoprotein. That is not going to be a big factor for that. Well, so, okay, read here. Nausea, slurred speech, lack of motor control. Lack of motor control, what does that tell you?
Brain?
Yeah, and this works in the brain. These are classic overdose symptoms of phenytoin. So phenytoin is not being broken down. So those aren't the symptoms of fluconazole. Fluconazole is an antifungal.
Psychotic symptoms, right? Yeah, because it says this clears So if it induces that cytochrome, then it can clear olanzapine, right? Yeah.
All right, so the patient experienced recurrent of psychotic symptoms, and olanzapine is an antipsychotic. So there's treatment failure going on here, right?
Yeah. Well, I mean, I feel like it's definitely due to something with this.
Carbamazepine is notorious as a DDI candidate. This thing interacts with so many different drugs. So it sounds to me as though this is being broken down too quickly.
Okay.
So there's probably enzyme induction. Which one? Which one? That's the one you have to
Okay.
try to figure out.
Like what cytochrome? Okay. St. John's wort, the killer of all success in medicine.
That stuff is nasty.
Keyboard. We found that essentially it uses the cytochrome 450
Yeah.
to metabolize the anti-rejection drug. And
So this is classic treatment failure
yeah.
because the cyclosporin is just being chewed up way too fast.
This is very similar. In fact, this is the exact same thing as our case study that we turned in. Almost.
Except the one I gave you was a bit more complicated.
Yeah.
But yeah,
But it's the same QIP.
yeah, 3A4. Yeah. Cyclosporin is, there's an ocular Restasis. You heard of Restasis?
I've heard of it.
It's for dry eye.
Got it.
How it works for dry eye, nobody knows really, but it works really well. And because putting it on the eye, very little, if any, gets absorbed systemically. Very well tolerated drug. Then there's a topical. Topical is not used that much anymore. There's better drugs. But if you take it orally as a anti-rejection drug, it was the mainstay for years as an anti-rejection drug. There are better drugs now. But yeah, if that stops working, your tissue is going to get rejected. It's sad, all because they took this herbal concoction. Sad. Sad. Yeah.
Would you mind writing a reference tree for student government for next year?
Yeah.
Perfect. I will email that over as well.
Sure.
Thank you so much.
Yes. No sweat.
QIP 3A4 metabolism. Does it have to do with this, the induction
Yeah.
of QIP?
Estrogens in general are mainly metabolized by 3A4.
Okay.
So that's pretty classic treatment failure. And why that person put her on carbamazepine, I have no idea,
Yeah.
because that drug is notorious as an interactor. Also, he should have looked at her and said, young female, reproductive age, good chance she's sexually active. I don't know, maybe because it's cheap. You'd think,
Drug, it's like hissing or
but you know, it's just, this hand doesn't know what this hand's doing, or you know, it's just, yeah.
It's crazy how like often drug interactions I'm sure like happen on a regular basis and the people start stuff all the time.
Yeah. You have to check for them.
Yeah.
And again, when you become an OT, before you treat someone, you have to know every drug they're on. That's the law.
Yeah.
That's the law. And you may catch something. They may be taking something for their dog.
Yeah.
It just, it's cheap. So it takes my pain away. So you figured out?
So we found that these two drugs together that
Yeah. Well, so sedation, ataxia, slurred speech, jerking motions of arms, that's carbamazepine toxicity, pretty clearly.
So the erythromycin affected how the liver metabolized the carbamazepine. Decreasing the and flavonoids.
Yeah. Macrolides are notorious 3A4 inhibitors.
Okay.
Azithromycin is not bad. Clarithromycin is really bad. Erythromycin is bad enough so that you get this sort of thing occurring. Okay, good. Oh, man, I gave them number 9. Think you got it?
I think so.
Yeah, indomethacin is an NSAID, non-steroidal anti-inflammatory drug. They decrease kidney function, and they decrease especially the excretion of things like lithium.
Yep.
So lithium levels soar. In fact, you're told when you go on lithium, the only NSAID you can take is aspirin, because aspirin doesn't affect it, but the others, all the others, ibuprofen, naproxen, any of the prescription ones, except for maybe Solindac, they all decrease excretion and your lithium levels go up. And that's, this feeling spacey tremor, that's classic lithium toxicity. So yeah, why the HE double hockey sticks, she was given that. That is a really powerful NSAID. That's got a lot of side effects. Why? No. Yeah, this actually happened. It's just,
So, I guess what would someone have to be going through then to be prescribed that for like the benefit risk, ratio?
indomethacin, if it's given for really short duration for very severe pain. Maybe her pain was just really, she had some sort of skin something or whatever. She had an abscess. An abscess is when they burst sometimes. You can get awful inflammation. I don't know. But
Better drug to give her than that.
she could have been given a low dose opiate for just a few days, or give her buprenorphine. Buprenorphine, she won't get hooked on it. Just give her weeks worth of buprenorphine. That'd have been fine too. Or codeine. Now you get hooked on codeine. Just give her codeine. Yeah, there are better options for that. And thing is, when you're on lithium, usually you carry a medical alert bracelet, or you have something in your wallet or something like that. Now people will get tattoos that says they're on lithium or something, because you have to be on nothing the rest of your life.
Oh, really?
Yeah, it's just how in the heck they missed that, or they didn't miss it, but they still gave them that drug. And that's a lawsuit. Call Sam. Call Sam. Literally, that's a call Sam. I just.
So is, yeah.
Yeah. Reduces levels of quetiapine. Yep. Yeah, she's got pretty serious schizophrenia there.
But she's the nursing program. It's like she has started with the same part of that.
Yeah, phenytoin. Yep.
She's just like,
Yeah, it's an inducer.
but
And it's an inducer of several cytochrome P450s, not just 3A4.
Okay.
But yeah.
I'm not sure. It might
Oh yeah.
I don't know.
That one's bad. Bad. You guys ready? You guys ready?
Yeah.
Ready? Okay. Let's have some reports from the different groups. We'll start with group number 1 over here. Who's your spokesperson? Go ahead. Tell the class what you guys discovered. Let's listen up.
So for our case study, we said that fluconazole inhibits the CYP450 enzyme 2C9 and 2C19, which increases the levels of phenytoin. So this leads to toxicity in the patient's blood, which causes symptoms of nausea, slurred speech, and lack of motor coordination, which are symptoms of an overdose.
Very good. That's precisely what happened. Very good. Okay.
CYP450, 2C9, and 2C19.
And out of those, 2C9 is the main one, frankly. That's the one that's of more consequence in this case. In that case, the phenytoin then levels are pretty high. And anti-seizures in general will tend to cause dizziness and unsteadiness. If anti-seizures get too high, you'll tend to get so-called ataxia, where you'll have just trouble. Your gait gets weird and you can't your motor coordination goes south, your balance goes south, your consciousness might even go south for that matter. So yeah, it's very good, very good. Okay, group 2. Oh, go ahead.
Carbamazepine has been shown to induce several P450 cytochrome, including 3A4 and 1A2. And 1A2 plays a role in metabolic clearance of olazapine. So the interaction may be attributed to injection of the 1A2 by carbamazepine, leading to increased first pass and systemic metabolism of insulin.
Very good. Carbamazepine was used pretty extensively because it's an anti-seizure, but it also is a pretty good mood stabilizer. Not used that much anymore because of drug interactions. The drug is very cheap. That's one reason why it was used quite a bit. It was called Tegretol when it came out, and it was given to lots of epileptics. It's extremely effective as an anti-seizure med, but it's just not used that much anymore because of the drug interactions. Very good, yeah. 1A2, in that case, is a big enzyme. Greg, what'd your group discover?
So the coating was just described as a prodrug inactive, so we're just active metabolite and converted by using cytosol CRP2B6. So when the patient was also prescribed Prozac, Prozac is also interact in a competitive fashion. So also these coating was turned into an active metabolite, which is why the patient still
So there you have treatment failure because of enzyme inhibition. SSRIs are notorious 2D6 inhibitors. So sertraline, Zoloft, is actually dose dependent in its inhibition of 2D6, but fluoxetine is a 2D6 inhibitor. Fluoxetine is Prozac, and then paroxetine or Paxil is a notorious 2D6 inhibitor. And in that case, you have a prodrug, it's not activated. Other drugs activated by 2D6 include tamoxifen, which is used for breast cancer. That needs to be activated. You can't give that with a 2D6 inhibitor either. There are other drugs for depression that are not 2D6 inhibitors, like citalopram or escitalopram. Lexapro and Celexa are the trade names of those drugs. Okay, that was group 3. Who's group 4? Yes, go ahead.
So mechanism is interaction between they interact and involve the cytosol people in the blood structure and they have more and that was the
And in that case study, none of the clinicians dealing with him knew that he took St. John's wort. None of them. Because he didn't think it was important to tell them about the teas that he drank. And this illustrates the importance, and I told some of you, Lydia, for example, is going to be an occupational therapist. She must know every drug a patient's on, Lydia. Herbals, that includes herbals, because herbals can interact with other drugs. And St. John's wort is notorious as an interactor with other drugs. So make sure you get those herbals down too. They're very important, as this case study illustrates. Okay, case study 5. Very good, very good. People who are on antipsychotics, it's very hard to get the medicine right. And when it gets right, you crack your knuckles and jump for joy. And then you do something like that. They're on something else, and then it messes everything up. And then you have to start over. It's a drag. Okay, next one.
So the oral contraceptive orthotricycline, when it's combined with carbamazepine, They both use cytochrome CYP3A4, which metabolizes estrogen. So when you combine the two, it then accelerates the metabolism of estrogen throughout the or contraceptive is no longer effective, which results in a positive pregnancy.
Very good. There's carbamazepine again, an inducer of 3A4. Okay, next group. Okay, does 3A4 have anything to do with absorption of the drug? No, it doesn't have to do with absorption. The drug gets absorbed regardless of 3A4. It has to do with the metabolism of the drug. Metabolism. So because of that metabolism, because it is an inhibitor of that particular enzyme, the levels will tend to soar. So it's not absorption, it's the metabolism part. So in that particular one, you can see that he's brought to the emergency room with sedation, nausea, tremor. That's due to an inability to metabolize the carbamazepine. Okay, good job, good job. That was number 7. Number 8. Good job, exactly right. Macrolides are particularly notorious, except for azithromycin. Azithromycin is pretty safe in that regard. Clarithromycin is quite bad, so is erythromycin. And there's another one called telithromycin. I think the trade name of that drug is Kedig. That drug should be pulled. That drug should have never been approved. It causes liver damage. If a doctor prescribes you Kedig, swear it off, say you don't want it. Terrible drug. No. Pull it. Okay, thought I just said that. Okay, Evan, your group.
The interaction of lithium and indomethacin causes like impact kidney, causes renal vasoconstriction and decreased renal secretion of lithium. So therefore, there's an increase of lithium that stays in the body, and that lithium toxicity causes side effects such as tremor.
Exactly right. So in that case, the interaction is with the kidney, not with the liver. And when you take lithium, you're told if you have pain, you can use acetaminophen or you can use aspirin. Don't use other NSAIDs because that will happen. And I was joking with that group that they all should, that patient should call Sam because that was a major faux pas. Whoever prescribes indomethacin, that's the kind of stuff lawsuits are made of. Seriously. All right, let's take a quick look at let's take a quick look at number 12. Number 12. Let's have someone read number 12. Amanda, can you read number 12 to us in a nice stentorian voice?
Amitriptyline 50 milligrams at bedtime for diabetic neuropathy for several years. On the death of her husband, she presented with symptoms of depression, and paroxetine was added to her medication regimen with the rationale that paroxetine would cause fewer side effects than an increase in amitriptyline dosage.
Amitriptyline.
Yeah, my bad. Amitriptyline.
Thank you.
3 days after the initiation of paroxetine therapy, the woman was brought to the emergency department by her daughter, who had found her asleep at 11 a.m. On awakening, the patient complained of dry mouth and dizziness. The emergency department physician, noting that paroxetine had recently been added to the medication regimen, changed the patient to chloroquine, which he thought would be less sedating. 3 days later, the patient was still very sedated and dizzy, and complaining of difficulty urinating. He was again brought to the emergency department where bladder catheterization over 2 years was recommended.
All right, so she's being put under the table by something, and her bladder's not working either. If the bladder's not working, that usually means you have an antimuscarinic effect. And which of the drugs on there has an antimuscarinic effect? Amitriptyline. Which cytochrome P450 is amitriptyline metabolized by? Cytochrome P450 2D6. What does paroxetine inhibit? 2D6. Then the physician switches her to fluoxetine. That's also a 2D6 inhibitor. He should have put her on low-dose sertraline. Low-dose sertraline wouldn't have caused that. But the poor guy probably didn't know that she was on amitriptyline. So this is amitriptyline toxicity. Amitriptyline is a so-called tricyclic antidepressant, but it turns out it's also used for peripheral neuropathy associated with long-term diabetes. But because the enzyme that degrades this drug was inhibited by these other medications, amitriptyline in her system soared, and amitriptyline also has antimuscarinic activities. And when it soars like that, it's going to sedate you as well, particularly if you're older. So that was the problem there. Get her off the SSRIs or put her on low-dose sertraline, and she would have been fine. And again, these are real cases. And it just has to do with doctors not knowing they're on other medicines, or they didn't get checked, or whatever. That's why, again, a medical history sometimes can do a much better job than all the tests in the world that you can run. A good, solid medical history is worth its weight in gold. And if they can't remember the drugs, what do? You tell them, get a Meyer bag, put all the drugs you take in the Meyer bag, bring them to me, and dump them out, and we'll go through them. That's how you know. And tell them to include herbal stuff too. And they tell them, well, I'm not sure. If you're not sure, include it anyway. Maybe it's a multivitamin. Maybe it's a food supplement you take. Maybe it's something that your dog takes that relieves your pain, so you take that too. Yes, that happens. Put it in a bag, bring it here. I won't judge you and what have you. Guys, if you're going to be non-prescribers, some of you, they're more likely to tell you than they are to tell their doctor. So do keep that in mind and include herbal stuff. I can't emphasize that enough. All right, we will finish this up, start on the heart, and go from there next time. Yeah.
Right, I really